Good afternoon and welcome to today's IAC webinar, Contrast Enhanced Ultrasound. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation and will try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest presenters. With us today are Dr. Stephen Feinstein, Dr. Michael Main, and Dr. Thomas Porter. Dr. Feinstein is Professor of Medicine and Director of the Echo section at Rush University Medical Center in Chicago, Illinois. Dr. Main is a cardiologist with St. Luke's Mid-America Heart Institute in Kansas City, Missouri. And Dr. Porter is Professor of Internal Medicine, Division of Cardiology at the University of Nebraska Medical Center in Omaha, Nebraska. These physicians are true experts in the field of Contrast Enhanced Ultrasound, and we thank them for being with us today. With that, I will now turn the webinar over to our first presenter, Dr. Stephen Feinstein. Doctor?
Thank you very much. I want to thank IAC very much for this opportunity, Bev, Kelly, and Joe. Kelly, thank you for the introduction, though I have to say the director of our Echo Lab now is Melissa Tracy, a good friend and an excellent physician. I also am excited to join this conference with Tom Porter and Mike Main, both great friends and colleagues. And to all the colleagues on the line and friends, welcome. Today, I'm going to focus on imaging of the carotid artery with Contrast Enhanced Ultrasound, and we're going to focus on the vulnerable plaque. I want to thank my colleagues at Rush University Med Center. We've been doing carotid contrast imaging since 2001, just a few years, and I have no disclosures to claim. So, diagnostic and therapeutic uses of contrast-enhanced ultrasound. It reduces risk. It reduces costs. It's not toxic. It is more accurate and reliable when you use contrast than without contrast. Healthcares are reduced, healthcare costs. It actually saves lives and changes therapy, and it's internationally accepted. When we look at the ultrasound microspheres, the biggest issue is, do they pass through the capillary vessels? Well, this was an image from 1984 in an intravital microscope looking at sonicated renographin in a capillary. And sure enough, as you will see now, the micro bubble or microsphere passes readily through the capillary, as do all the contrast agents today, and are not trapped in the capillary vessels. So we're going to now look at vascular imaging and shoot down to carotid arteries, jumping over all the other vascular targets we could look at. Let's look at the carotid artery, the lumen, the IMT, and angiogenesis. This is a cartoon of a carotid artery of a patient. As you can see, we're going to focus on the common. Right here, the bifurcation splits into the external, the internal, and this is the common. The bifurcation is often where most of the disease is. What is the added value of doing contrast when we do carotid imaging? Well, you can see the lumen, just like LVO in cardiac patients. We can define the IMT and the plaque. We can look at true volumes. And of course, we can look at intraplaque angiogenesis or neovascularization. This is one of the first images we performed. This was a carotid artery image of a patient. The neckline is seen up here, the shoulder is here, the head is here, and in this still frame, you can see the ulcer identified and the plaque. Whereas at the very beginning, it was not possible to identify much of anything. So once the contrast comes in, the lumen became identifiable, the IMT became readily apparent, and the plaque and the ulcer equally apparent. In the next image, this was done a couple years later, and we began to notice, to our surprise, that the actual plaque of a patient carotid artery was filled with blood. And you can see, just like the capillary vasculature I showed earlier, the microspheres of contrast ultrasound are actually coursing through this plaque. The plaque is not concrete, it is not solid, it is filled with tumor, blood vessels. So, subsequently, Hans-Peter Westcott from Hanover, Germany, performed the study in a patient with carotid disease. As you can see, this is the lumen, and here's the plaque. But in this particular case, that's not the entire story. This is like an iceberg. The true plaque, as you can see, is actually much bigger, and this is what we call the Glaikoff phenomenon, or positive remodeling. So the entire plaque is seen here with negative remodeling, positive remodeling, and of course, filled with neovascularization. Let's then talk about what is the vulnerable plaque using Contrast Enhanced Ultrasound. This is a specimen from a patient who had carotid artery surgery. What you'll notice is the core is necrotic, just like a tumor. And as we dig a little bit deeper, you notice inside the plaque itself, these microvascular vessels are really very small. This is a red cell here. They're designed to bring oxygen to the core of a plaque, which is quite hypoxic. Unfortunately, these very small vessels, while they're effective in bringing oxygen, rupture because they do not have parasites, they're not stable enough. When they rupture, the red cell leaves the vessel into the matrix, as seen here, deposits its iron, which never leaves, and can be stained then to show that this patient had multiple ruptures of these small vessels inside the plaque. Additionally, when we stain with a CD31 stain, which is an endothelial stain, it shows the new blood vessels within this plaque. They very much look like the new blood vessels of a cancerous tumor. Is the composition of the plaque related to outcomes? This study from 2010 by Hellings et al. Looked at 815 carotid specimens over the course of 3 to 4 years, and then predicted which patients would have untoward events, heart attack, stroke, and death. They found that the presence of plaque hemorrhage and increased vessel density are independently associated with future cardiovascular events. This was a really dramatic study, prospective study looking at 815 subjects. So you would say, oh, a plaque is vulnerable based on its lipid core, muscles, macrophages. No, actually, they didn't find any relationship. The two things that stood out were intraplaque vessels and plaque hemorrhages. And as you can see from this graph, the events are on the left. The time is on the right, on the axis here, X and Y. The only two boxes that show events over time are plaque hemorrhage and vessel density. A common one that we thought would be an indicator of bad outcome would be a lipid core. No such thing. Subsequently, numerous authors now have looked at this subject, published on it, and in fact has held up. This is a nice cartoon diagram of the images I have just shown you. And the same authors then went on to say it is possible to visualize a vasovasorm in plaques and to follow their progression with contrast-enhanced imaging. And we do so today. Where's the future? This is a 3D image of a patient at Rush. We did a clinical study of 19 patients here. What you can see in the 3D image of the carotid is the plaque and the vasovasorm within the plaque. This took all of about 15 seconds to record. The future will, of course, be performing 3D carotid imaging with contrast to look at the lumen, the plaque volume, and intravascular neovascularization. So what can we then say about 3D contrast-enhanced imaging for the future? It'll reduce time, reduce operator dependence. We'll get 3D volumes, not 2D. We will not have out-of-plane errors. And the spatial registration is reproducible, allowing serial reproducible monitoring of disease, monitoring of patients. There will be questions to follow. Many of these issues can be approached and accomplished in a good lab, but there are several issues that need attention, and I thank you very much for your time.
All right, thank you, Steve. We'll move on to the second portion of the presentation, and that's a brief review of safety experience with ultrasound contrast agents. These are my disclosures. A brief historical perspective initially. In October 2007, the FDA imposed a black box warning on the ultrasound contrast agents that were available in the U.S. at the time, citing several patient deaths and many severe cardiopulmonary reactions which had occurred in close temporal relationship to ultrasound contrast agent injection. The FDA then performed an epidemiologic-type study to determine what were risk factors for adverse events with ultrasound contrast agent. These are the initial FDA actions almost 10 years ago in October 2007. As I mentioned, they added a boxed warning or black box warning to the product label for Definity and Optison, the two agents available in the U.S. at the time, highlighting the risk of serious cardiopulmonary reactions within 30 minutes of administration. They also added multiple new disease state contraindications. These included patients with worsening or clinically unstable heart failure, patients with acute myocardial infarction, patients with serious ventricular arrhythmias or those at high risk due to QT prolongation, patients with respiratory failure, and also patients with severe lung disease, pulmonary emboli, or other conditions that might predispose to pulmonary hypertension. They also at that time mandated a 30-minute monitoring period following contrast administration in all patients, including ambulatory outpatients. Well, a number of investigator-initiated studies were published in the immediate aftermath of these warnings. This is one of the first of those, a retrospective study looking at acute mortality in hospitalized patients undergoing echo either with or without an ultrasound contrast agent. And as you can see here, of these 18,700 patients, about two-thirds underwent unenhanced echocardiography, one-third with the contrast agent Definity, and vital status was available for all of these patients at 24 hours after contrast agent administration. And these are the results. The overall mortality was no different whether the patient received an ultrasound contrast agent or not. The overall mortality, about 0.4%, attesting to the critically ill nature of patients who are in the hospital. It was apparent, however, that patients who received a contrast agent did have some differences with respect to patients who underwent unenhanced echo. Patients who received a contrast agent tended to spend more days in the intensive care unit. They had a higher prevalence of chronic obstructive lung disease and had lower left ventricular ejection fraction. Following this, a number of investigator-initiated studies were published. Many are shown here in this meta-analysis published by Kawaja and colleagues in the American Journal of Cardiology in 2010. And as you can see, there's about 5 million control patients and 211,000 patients who received an ultrasound contrast agent. And this figure shows the pooled odds ratio for all-cause mortality across these studies between patients undergoing and not undergoing contrast imaging. And as you can see, the point estimate here actually favors contrast administration. No evidence for increased mortality in patients who received an ultrasound contrast agent. The FDA was not completely satisfied with these investigator-initiated studies, however, and asked the two existing U.S. manufacturers, Lantheus Medical Imaging and GE Healthcare, to each perform 3 studies: a pulmonary hemodynamic study, a critically ill propensity-matched database study, and a routine clinical care registry. In the pulmonary hemodynamic study, about 30 patients from each manufacturer underwent a right heart catheterization. Now, half of these patients at baseline had normal PA pressures, half had elevated PA pressures. They were then administered a clinically relevant dose of an ultrasound contrast agent. There was no change in pulmonary artery pressure or pulmonary vascular resistance, no deaths, no serious adverse events. In the critically ill propensity-matched database, a large number of critically ill patients who underwent echocardiography with a contrast agent were matched with patients similar patients who underwent echocardiography without a contrast agent. And as you can see, no increase in mortality in the contrast patients. In fact, in the LMI study, the Lantheus medical imaging arm, the point estimate and fairly narrow confidence intervals actually favored administration of contrast. And then in the routine clinical care registry of about 1,000 patients each, there were no deaths, no serious adverse events. This is just progression of product label changes, shown in this case for Definity, but an analogous situation exists for Optison, again, the two agents that were available over this time period. Following initial product approval in 2001, of course, the boxed warning was added in 2007, and serious cardiopulmonary conditions were added to the contraindication list. In a 2008 revision, the boxed warning remained in effect. However, the serious cardiopulmonary conditions like acute myocardial infarction or worsening heart failure were moved to the warning section. And then in a 2011 revision, the FDA allowed that serious adverse reactions are uncommon and occur typically within 30 minutes of administration, and they also deleted the 30-minute monitoring period. You'll note, however, that as of this product label revision, cardiac shunts remained a contraindication. There is one risk of ultrasound contrast agents with which we ought to be familiar, and that is the risk of serious allergic reaction, which rarely occurs. This data, again, from the Kawaja meta-analysis from the AJC in 2010, looking at studies in which allergic reactions were assessed, about 110,500 contrast injections. Of these, allergic reactions occurred in 0.009%, and very serious reactions, anaphylactic or anaphylactoid reactions, occurred in 0.004%. So a small but real risk of serious allergic reactions. Why do these occur? What is the etiology? Well, these are due to a fairly recently described variant of the type 1 hypersensitivity reaction known as CARPA reactions, or complement activation-related pseudo allergy. There are a lot of drugs which may elicit CARPA reactions, of course, ultrasound contrast agents, but also radio contrast media. So these type of reactions can be observed in the cardiac catheterization laboratory and also in patients who are undergoing CT scans with contrast enhancement. Common signs and symptoms of CARPA reactions, similar to any other type of allergic reaction. In serious cases, angioedema, bronchospasm, cyanosis, or cardiovascular collapse with hypotension can occur. Lower back or flank pain is also a manifestation of CARPA reaction. It occurs somewhat more frequently, but is less serious. And, of course, in less serious cases, pruritus and urticaria may occur as well. How do these CARPA reactions differ from what we more frequently associate with allergic reactions, the IgE-mediated type 1 reactions, which can occur with food or antibiotic allergy, for instance? Well, with IgE-mediated type 1 reactions, a reaction occurs after repeated exposure. The reaction tends to be stronger upon repeated exposure. It won't cease typically without any treatment, but there's a fairly low reaction rate within the population at large. In CARPA reactions, no prior exposure is necessary. This could occur on first exposure, so we need to be aware of that. The reaction tends to be milder or even absent upon repeated exposure. Spontaneous resolution is the rule, and there's a higher reaction rate amongst the population as a whole, particularly in women and also in so-called atopic individuals, those with pre-existing food or drug allergies. So what can we do to mitigate this risk? Well, at our center, we've provided allergy kits in close proximity to imaging platforms, just a commercially available tackle kit stocked with drugs that would be necessary to treat allergic reactions in the acute phase, the most important component of which is the auto-injectable epinephrine pen, or EpiPen, which is necessary in cases of extreme allergic reaction, including patients with vascular collapse. Well, let's turn to the lone remaining contraindication, shunts, which we talked about just a little bit ago. A few years ago, in 2013, the International Contrast Ultrasound Society published a position paper arguing that the shunt contraindication is not evidence-based and that safety concerns related to shunts or to contrast agents are related to radio-labeled macroaggregated albumin, which is used in ventilation perfusion scans of the lungs. Now, MAA itself, as we'll see, is not contraindicated in patients with shunts, and it was the opinion of ICUS that the weight of evidence supports use of ultrasound contrast in agents in patients with shunts when they're clinically indicated. This is just a comparison of the size of macroaggregated albumin and Optison and Definity, again, the agents that were commercially available at the time, Lumason not yet approved in the United States. Macroaggregated albumin with a particle size of 10 to 150 microns is potentially capable of occluding arterioles, yet carried only a precaution for use in patients with intracardiac shunts, whereas Optison and Definity, with sizes ranging from 1.1 to 4.5 microns in diameter, potentially only capable of occluding a capillary in an extreme case, carried a contraindication in patients with intracardiac shunts. This is just some data from Kalra and colleagues published in JACC Cardiovascular Imaging in 2014. They studied in their clinical lab 39,020 patients. 38,602 of these had no known intracardiac shunt, whereas 418 of these patients had a known intracardiac shunt and nonetheless received an ultrasound contrast agent. And as you can see, there were no primary adverse events and no transient ischemic attacks in these patients with known cardiac shunts. Well, I think based on all of these considerations, the FDA recently announced that they were going to rescind the shunt contraindication for Optison, Definity, and Lumason, and this is just a portion of the updated product labeling for Optison. The shunt diagnosis has now been moved from contraindication to the warnings section, and FDA advises us that when we're administering an ultrasound contrast agent to a patient with a cardiac shunt, that there is the potential for microspheres to bypass filtering the lung and enter the arterial circulation, and they ask us to assess patients with shunts for embolic phenomenon following contrast administration. That's the official labeling now for all three agents. And finally, just some data from a large outcome study looking at outcomes in critically ill patients undergoing contrast echocardiography. This study started with about 1 million transthoracic echocardiography patients who underwent echocardiography while hospitalized in an ICU setting. This used the Premier Perspective database, a very large hospital billing database. From these million patients, ultimately 16,000 contrast patients were matched with 16,000 patients who underwent echocardiography without a contrast agent. And this is the top-line data from the study, just looking at overall mortality at 24 hours. And as you can see here, the absolute mortality in patients receiving a contrast agent, here in orange, was about 2% versus 3% in patients undergoing echocardiography without a contrast agent. So a 1% absolute lower mortality in patients undergoing contrast echocardiography. The reason for this was beyond the scope of this publication, but it's certainly possible that earlier and more accurate diagnosis led to better therapy in patients receiving an ultrasound contrast agent. So just a few take-home points with respect to safety. I think it's fair to say that ultrasound contrast agents are safe by any reasonable standard. We should be aware that there's an approximate 1 in 10,000 risk of anaphylactoid reaction. We ought to be prepared with allergy kits, including auto-injectable epinephrine. And finally, I think it's pretty clear now that judicious use of ultrasound contrast agent actually can improve outcomes, particularly in difficult-to-image patients in the intensive care unit. And with that, I will turn this over to Dr. Tom Porter.
Thank you very much, Mike and Steve and Bev, Kelly, and Joe. We want to spend the last few minutes before we go to questions on the uses and how we recommend using the ultrasound contrast agent. I think this is very important because we're seeing an ever-expanding use of ultrasound contrast agents and understanding better their potential in many areas. But we want to focus just on the diagnostic applications today and to discuss the potential for using it. Now, the utilization of contrast agents also requires, obviously, some modifications in your ultrasound instrumentation, and our vendors have been very good about providing that to us. There are two ways this can be done. There's low mechanical index harmonic imaging, which we recommend using a mechanical index on your transducer of 0.2 to 0.3. And then there's the very low mechanical index nonlinear type of activity, which again is available on most systems today. But this is unique in that it requires a mechanical index of less than 0.2 and probably provides the best method of optimizing contrast for left ventricular opacification, which is the FDA-approved indication for using ultrasound contrast. The low MI imaging techniques take advantage of the fact that the microbubbles, even at 0.3 or 0.25 mechanical index, have this second harmonic response. And so a transducer can be set up to receive that signal, and although it's a lower signal than the fundamental frequency, it elicits primarily this activity from the microbubbles and very little from the tissue or any artifacts like side lobes that tend to cause a lot of interference with fundamental imaging and allow us to see good ultrasound contrast in the left ventricle and not any of the artifacts that typically accompany fundamental imaging. Now, when is that going to be useful to us? Well, it's going to be useful to us whenever we need to see regional wall motion very well. And that, as you know, comes in, day out in any stress echocardiography laboratory where it's recommended that you see all the segments very well. Certainly, if there's two contiguous segments that are not visualized well, this is what we feel is the current criteria that's used to use ultrasound contrast in the stress echo lab. But if you're asked to evaluate a patient with chest pain or remote history of chest pain and a non-diagnostic EKG in an emergency setting, again, regional wall motion of all and assessment of all segments is critical. So we recommend using contrast there. The contrast should also be used in critical care settings where windows are difficult in many cases, patients on ventilators, obese patients, patients post-surgical. In this setting, contrast can be extremely useful, as we'll find out in a moment. And then any quantitative assessment of the ejection fraction, where, again, it's obvious that we need to see all the segments very well to accurately quantify any change in ejection fraction. Contrast has been shown to be very, very helpful there. Because the contrast at a very low mechanical index or low mechanical index allows the microbubbles to reach the apex, this has been very helpful to use it in detecting apical variants of hypertrophic cardiomyopathy or other non-ischemic cardiomyopathy patterns that require that pattern to make the diagnosis, such as the stress cardiomyopathy or non-compaction. Here's an example of a 73-year-old patient that just came to the stress echo lab and had the tissue harmonic imaging used initially and was felt to have fairly normal resting wall motion, as can be seen here. The patient was being evaluated for a kidney transplant, but the resting images that were obtained shortly after their resting echo, which was done prior to the stress echo, the sonographer did a little better job of getting this apex in a little bit better, and there was a suspicion now of a distal septal and apical wall motion abnormality. But with low mechanical index harmonic imaging, you can see how much better this apical wall motion abnormality is visualized here. And even though this technique, which, as I said, it just takes advantage of that second harmonic signal, it still destroys a few of the microbubbles in the near field, so you see a little bit of swirling there. It's still very good for picking out this apical wall motion abnormality and better defining the segmental extent of the abnormality. And in a multi-center group led up by Dr. Hoffman several years ago, this low MI harmonic imaging modality was used and compared to unenhanced echo and to cardiac MRI, as well as invasive left ventriculography, in the ability to pick up regional wall motion abnormalities. And they found that the accuracy of a contrast-enhanced echo with low mechanical index imaging had the highest accuracy for detection of these regional wall motion abnormalities, about 10% better than unenhanced echo, and certainly better than invasive angiography, which usually at best can do a biplane image of the ventricle, and equivalent to cardiac MRI, which of course has the advantage of being able to do this without any contrast, but still providing a bedside technique with high accuracy like this is critical in certain clinical situations. This kind of outlines those clinical situations where it may be beneficial. This was a study done by Dr. Kurt at Baylor University in conjunction with Dr. Zogby, which looked at the potential for a contrast-enhanced echo to improve the ability to assess ejection fraction and make a non-diagnostic study diagnostic. And you can see that the ejection fraction, which is a critical factor in regional wall motion in these patients, was not even able to be detected on the unenhanced echo in 12% of cases. That improved to 0.3% that were uninterpretable after using low mechanical index contrast enhanced imaging. In addition to that, several of the ejection fraction assessments here, which are shown in blue for greater than 50%, yellow for 30 to 50%, and less than 30% in red, were changed when using a contrast enhanced echo. In fact, these investigators found that in over 35% of the cases, the use of contrast added to unenhanced echo resulted in either a change in the diagnosis that led to a change in medical management, or it led to one less diagnostic procedure required to understand the patient's diagnosis. So this technique, with just low mechanical index imaging alone, just using that harmonic behavior of the microbubbles, shows great potential in the intensive care unit setting, as well as in any situation where windows can be difficult, to lessen the need for additional diagnostic testing and make a study more reliable and definable for the referring doctor. Here are some specific situations where we clearly see better delineation, in this case of an apical hypertrophic variant with the low mechanical index imaging modality when compared to unenhanced echocardiography. And in the setting of isolated non-compaction, you can again see that because low mechanical index imaging doesn't produce any myocardial contrast, it delineates very nicely the deep recesses of contrast-enhanced regions in that non-compacted layer and the little trabeculations of muscle and their extent when trying to make this diagnosis, and clearly beneficial in defining that non-compaction to compaction ratio that's required for the diagnosis. Really requires contrast here in order to be able to delineate that when compared to a non-contrast study. Similarly, the Doppler echocardiography findings of left-sided disease, for example, aortic stenosis or picking up pulmonary venous signals, is often helpful to use contrast for that as well. This is an example of a patient that had very difficult windows but had definite calcific changes on their aortic valve. And you can see during an infusion of contrast, a signal that was almost impossible to get without contrast was picked up very nicely by lowering the Doppler gain to about 10 to 20%, infusing the contrast to get rid of the noise and picking up very nicely the aortic stenosis signal. We found this to be useful in several settings to add the Doppler to a contrast if the patient's getting contrast for another reason. This is an example of a patient that had a pulmonic valve prosthesis put in, was having right heart failure symptoms, and we were asked to evaluate the pulmonic prosthesis, which was actually a valved conduit, and it didn't appear that they had a very high gradient at this time. We did infuse contrast just to better visualize the left and right ventricle, but also during that contrast administration, Dopplered this RV, right ventricular outflow tract, and you can see very nicely the signal from the stenosis graph was picked up here when it was not seen in an unenhanced echo, and this turned out to be an actual stenosis in the graft beyond the valve prosthesis right prior to the bifurcation, which was delineated here by CT. Mike Main showed this slide already. Again, I want to point out the fact that if we use contrast in the setting of critically ill patients, this was looking at mortality at 48 hours in patients admitted to an intensive care setting where contrast was utilized versus when it was not utilized, and the patients were propensity matched so that they had an equivalent number of risk factors for increased mortality. You can see that adding contrast in that first 48 hours significantly was associated with a significantly reduced mortality in this patient. In fact, a 28% reduction in mortality was observed, and I don't think it's because contrast was therapeutic in any way in this setting, but I think it improved, as Mike pointed out, or inferred, is that getting the diagnosis early with contrast is critical to advance in improving patient care, and I think this is pointed out both in the CURT study as well as in this study. Now, I want to conclude by just discussing a little bit about the very low mechanical index techniques that are on, again, most of the commercial systems. They've been available for over 15 years, and now they're on systems, but we have a little problem with our vendors, perhaps, in helping us understand where they're located or how to get them. But these are techniques that now take advantage of the fact that microbubbles at very low mechanical indices, when insonified with pulses of either alternating polarity, as can be seen here, or alternating amplitude, will elicit what we call a nonlinear response. This is the microbubble response here, which looks like a lot of scribble on paper here, but it actually amounts to a signal that's measurable when we hit them with this mechanical index of just 0.15 or 0.18. While tissue or any valve, for example, will basically be subtracted. They only respond linearly at these very low mechanical indices, and they produce no signal. And what's unique about this is that we can detect both the fundamental frequency and the harmonic frequencies of this, so that we get a much more robust signal from the microbubble at this very low mechanical index, while having built-in background subtraction. What does this look like? Well, on the systems, it's available in different forms, but we did do some investigation for the 2014 guidelines and found that these companies here all have these modalities of either alternating polarity or alternating amplitude signals. They each have their advantages and disadvantages, but they clearly improve the signal we get from the microbubbles at a very low mechanical index and minimize any destruction, and this has extreme potential in several situations. One, it results in less apical swirling and better delineation of the apex, like you saw with the harmonic images. We now see less of that swirling because of less microbubble destruction. We see improved basal segment visualization, and we can see myocardial contrast enhancement that allows us to look at perfusion and even detect subendocardial wall thickening abnormalities that improve our ability to detect regional wall motion abnormalities. This is what this looks like. You can see that before the contrast arrives in the left ventricle, there's no signal from the valves or the myocardium because they all are responding linearly. And when the microbubbles come, even at a very dilute infusion rate, we see nice left ventricular opacification followed by myocardial contrast enhancement. And that becomes very useful in situations where we're asked to see patients at the bedside where the windows are difficult, even with high mechanical index tissue harmonic imaging here, like this patient that was just admitted for atrial fibrillation, was spontaneously converted. They wanted a rapid echo because the question whether she had some embolic phenomena occur. So contrast was utilized to look better at this apex. You can see here's the low MI harmonic image, which suffers a little bit from contrast destruction in the near field. However, when we switch to this very low mechanical index imaging modality here, this is just one switch of a button from here to here, we can better delineate apical abnormalities, and here identify this left ventricular apical thrombus and the extent of the regional wall motion abnormality. Here's a patient that arrived in the emergency room. Here's their apical two-chamber view here. This patient had difficult windows. It was post-cardiac arrest with a non-diagnostic EKG. They had been shocked. We can see here this inferior wall motion abnormality was detected when we used the very low mechanical index imaging modality, whereas they weren't being seen with the non-contrast or unenhanced tissue harmonic image. The thing that's unique about this is that these regional wall motion abnormalities are in the basal segments, and we've seen with the very low mechanical index imaging technique that they are truly detectable. I think you can see it was difficult to see the inferior segments here, but in this plane right here, this inferior wall motion abnormality came in very well. The key components of the exam are the frame rate, the gain, the imaging mechanical index, and the flash mechanical index. What is typically done in these settings with the very low mechanical index imaging settings is that you'll see good myocardial contrast enhancement and good left ventricular cavity opacification, but we'll use a brief high mechanical index impulse to clear the myocardium of contrast and visualize its replenishment, but also to visualize the regional wall motion very well, as is depicted in this patient here during stress. You can see this is right after that high mechanical index impulse here, where it looks like regional wall motion is pretty good in the distal septum, apex, and apical lateral segments. But during the replenishment phase, this is literally 2 seconds later, just while that contrast now appears in the myocardium, you can see there now is a subendocardial perfusion abnormality, and now you can see that it's not thickening as well. This patient had a 70% mid-left anterior descending lesion, which was really only detectable during the replenishment phase of contrast, where we were seeing a subendocardial wall thickening abnormality that was not evident when using contrast just for the left ventricular opacification indication, and transmural wall thickening appeared normal. So we've seen these subendocardial wall thickening abnormalities during dobutamine stress, and they've been very helpful for improving regional wall motion analysis during dobutamine stress when looking at that replenishment phase. The perfusion imaging that we do with ultrasound contrast and the very low mechanical index imaging is basically an extension of using it for left ventricular opacification, in that we apply these brief high mechanical index impulses during the study and analyze regional wall motion on the first images after the high mechanical index impulse, and then also look at myocardial contrast enhancement. And we found that a delay in replenishment that exceeds 2 seconds during any type of stress imaging is typical of a perfusion defect. Under resting conditions with normal capillary blood flow, the contrast enhancement occurs within 4 seconds, but during stress imaging, it should occur within 2 seconds. So we typically look at the regional wall motion and then also look at the replenishment of contrast as a function of time to see if there's perfusion defects that sometimes occur in the absence of a wall thickening abnormality. Here's a patient during dobutamine stress echo that has a perfusion defect that you can see all along the anteroseptal and apical territory here, as well as the infralateral segments, while wall thickening appears primarily abnormal just in the distal anteroseptal and apical segments. The patient had multivessel coronary artery disease, which was much better detected because of the perfusion, by the extent of the perfusion abnormality, whereas wall thickening really appeared only confined to be abnormal in the LAD territory. Contrast has been better at identifying the extent of the perfusion abnormality and the extent of the coronary disease better than wall motion analysis. I just want to talk about the key tips again for sonographers to use when using this very low mechanical index imaging technique. Again, the very low mechanical index imaging prevents the swirling, and so it's advantageous over low MI imaging for that. It requires less contrast, and we do recommend advancing the time gain compensation a little bit in the near field to better detect perfusion, and some of these require just some tips that we advise you to go back to the American Society of Echo guidelines in 2014 to better delineate. I would also remind people that a perfusion code now exists, a Category 3 code now exists for utilization of perfusion imaging as an add-on to the following CPT codes, and we hope that utilization of this will, again, identify to Medicare the importance of perfusion imaging in our daily practice. So to conclude, I would recommend using contrast when critical to evaluate all segments, rest or stress studies for any patient with shortness of breath and chest pain, because it improves the regional wall motion abnormalities that can be detected. It allows for quantification of the left ventricular ejection fraction. Very low mechanical index imaging seems to be preferred over low mechanical index harmonic imaging. I would talk with your system's representative to see how this is accessible on your system. This is one area where our vendors really need to help us a little bit in improving the value we get out of contrast when we use it. Don't forget to use Doppler-enhanced data when possible to improve left-sided signals especially. Saline contrast certainly improves the right-sided signals, but the left-sided signals are better detected with contrast. And then perfusion imaging, certainly it requires some expertise, but it certainly has the potential to improve your detection of coronary artery disease and prognosis. And I'll close there so we have time for questions.
Okay, thank you, Dr. Porter. At this time, we'll begin the Q&A session. From IAC Echo, I'd like to introduce Bev Gorman, Director of Accreditation, and Sandy DePetris, our Senior Clinical Specialist, who will assist with questions today. Sandy, would you like to start us off?
Sure, thanks, Kelly. Dr. Feinstein, I have a question for you. There were several on the list that were very similar, but some people would like to know what kind of contrast you're using for carotid ultrasound and what type of dosage are you giving?
Thank you very much, and thanks for the questions. We've used all the contrast agents. Every machine is a little bit different, so you'll have to adjust, as Tom said, a very low MI with high contrast settings to highlight the black and white issues. We really don't want gray. So all the agents work well. The second part was the protocols.
Protocol and dose?
We find that we can use very low doses in a bolus injection, and we sometimes will do 2 or 3 repeat boluses to get an adequate opacification of the lumen, which then allows the vasovasorum to fill. If you're underdosing and the lumen is not fully opacified, you will not see intra-plaque neovascularization.
So, Dr. Main, Bonnie's asking if there are any thoughts or best practice relative to use of contrast outside of the hospital setting.
With respect to safety, Bev, is that the question?
Yes, yes.
I don't think that really I would recommend, or really probably anybody would recommend any differences there. I think we ought to be prepared to treat these rare allergic reactions wherever they occur. That would include in the physician office setting or the hospital setting. We usually like to have a physician in proximity when we're using a contrast agent, certainly not necessarily at the bedside, but within the lab or proximal that they can get back to the lab if there's any kind of a reaction. Again, these are very, very rare, but I would treat those exactly the same, prepare for these type of reactions exactly the same in the physician office as I would in a hospital outpatient department setting.
Dr. Porter, I have a question for you. Have you seen contrast Doppler evaluation overestimate velocities with contrast use?
Theoretically, but it's not possible to do that. But I think the problem is you really have to turn the gain down. And in that setting, I think you will find that you can get a very good bright signal. You certainly don't want to take some of the haziness or the non-very bright signal that goes beyond what is the very dense opacification that you would expect to use. That's where I think people tend to overestimate the Doppler signal. So you want to turn your gain down to about 10 to 20% so that you're eliminating as much as you can any of the noise that typically accompanies a contrast infusion, and then just choose the densest part as your where you would choose your peak velocity, and not choose any of the haziness that goes above that. That's where my experience has been that there's been overestimation of the actual gradients or pressures.
Dr. Feinstein, Michael is asking, are the microvessels formed in an attempt for the body to reconnect the carotid to revascularize the area consumed by plaque?
Good point. These small blood vessels in tumors, and a carotid plaque is a tumor, the core becomes very hypoxic. And what drives that then are tissue hypoxic factors and generating VEGF. So within 24 to 48 hours, you will have new blood vessels in any area that is hypoxic and not connected by capillaries. So about 250 to 500 microns is all the farther you can get away from oxygen, and then you will grow these in any tissue of the body. So these are not necessarily developed to collateralize the carotid flow. They're actually to feed a necrotic core of a tumor.
Okay. I think that this would be probably Dr. Porter. Jorge asks, does CEUS, contrast use, have advantage over no enhanced ultrasound for detection and characterization of tumors?
Oh, that's a very good question. Yes, I think in this setting, the work originated by Roberto Lang's lab with Kirkpatrick showed that the same type of technique I was describing, where we use the very low mechanical index imaging with a continuous infusion or even a slow bolus of the ultrasound contrast agent, will help determine the vascularity of any mass you see on an echocardiogram. So you may see something in the left atrium or right atrium, and so you want to get a view which puts that tumor as close as possible into the near field of your transducer, and then infuse contrast as you would normally do for any other type of study, and there you will see whether that enhances or not. And they took it one step further. They gave that little high mechanical index impulse, like I advised to do for assessing the regional wall motion and perfusion. The brief high mechanical index impulse can be applied to the tumor as well, and that rate of replenishment, again, gives you an index of what the flow is in that tumor. Typically, stromal tumors like myxomas or fibroblastomas will have a small amount of replenishment and a small amount of contrast, while malignant tumors tend to have more intense contrast enhancement that almost mimics the enhancement you see within the myocardium. So I think it has been shown to be a very useful tool to supplement to your other echo techniques you use in evaluating an intracardiac mass.
We've had several questions here, Dr. Main, about signing a consent form before the injection of contrast agents.
Well, I think that's more of a medical legal question, obviously, than a medical question. People have varying opinions on that. I think probably Steve and I would disagree on that. Our lab actually started having patients sign consent in the wake of the FDA warnings in 2007. And our thought on this was, we are not injecting saline. This is a compound that could have a biologic effect similar to any other kind of contrast agent. So we have had patients sign consent forms, and in that consent form, we basically indicate that there's a very rare risk of serious allergic reaction, about 1 in 10,000, that these agents are FDA approved for the indications we're using them for, and most patients are very happy to sign that. In the case of patients who are hospitalized, sometimes you have to have patient family members participate in that. Slows us down a little bit, but that's been our practice over the last 10 years.
Okay, and Dr. Feinstein, I have one for you. Terry asks, do you use contrast for every carotid duplex scan? And if not, who makes the decision to use the contrast?
Good question. Let me just follow up on Mike's thought regarding the consent, if I might. No, we do not and have not consented anyone since 1998. But then again, we do not consent people for SPECT, CT, MR, or any other FDA-approved drug. And that has become an issue. So if we're going to do that, then we'll do it with all of them. Regarding carotid contrast imaging, it still is not an approved use of the current contrast agent, so we do call this off-label. We have been using it in clinical trials and on grants and research approaches. In a routine basis, no, because what you will find, there is no CPT code to get reimbursed for your carotid imaging. So that, like everything, discourages its use for routine clinical use.
I think I have one question here for Dr. Porter, maybe some suggestions or steps that they can take to minimize swirling in the apex.
Yes, those are very good. And again, I would recommend going and getting that 2014 guidelines, which is available to you free on the Internet. There's some good examples in there and movies from that 2014 paper, but what we have found most effective at reducing swirling is using the very low mechanical index imaging, if you have it available, as opposed to low MI imaging with harmonics, just because that tends to be more destructive. If you don't have that available to you, you have some other choices. You can further lower the mechanical index with just your B-mode low MI harmonic imaging, again, to diminish some of that destruction, and you can move the focal point up closer towards the apex, because that decreases the scan line density in that near field and will minimize the destruction there. So you can just transiently move your focus up there to the near field, and that should, again, minimize some of the destruction you're seeing. You don't want to take the mechanical index down too low when you just have a B-mode harmonic, because you tend to lose a lot of the signal from the microbubbles. But if you do have that, and I think most systems, talk to your vendor, most systems now, just for the application of LVO I'm talking about here, have switched over to those multi-pulse techniques that I described, the alternating polarity or alternating amplitude signals for their LVO package. And they should be able to help you find that, and you will find a tremendous improvement in your amount of signal you're getting from your contrast, and hopefully less apical swirling.
Thanks again, everyone, and a very special thank you to our guest presenters for sharing their insights with us today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Library's website for 3 business days. In the upper left, you'll click on My Webinars. Look for the title of this session, Contrast Enhanced Ultrasound. Beneath this title, you will see the link, Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.